I'm gonna be off. I'm gonna be off camera for a moment. I need to get some nutrients in my body. Eat.
Sounds good. Welcome. We just for everyone's awareness, we just went live, so we're public now, and we are just waiting for a few more of our members to join, and we will go ahead and get started momentarily. Thank you all for being here. Happy Thursday. Happy New Year. This is the first time we're seeing you all in the New Year, so Happy New Year.
Happy New Year as well.
Year. Welcome to a fabulous, wonderful, going to be successful 2026.
I can't be mad at your optimism there, but
We're gonna make it through, Eddie. You know?
one way or another.
Right, we gonna make it through, right? I'm gonna be praying just through.
Mhm.
And thank you for all the wonderful work you do. I'm talking to you providers because, oh my goodness, in this world and in this day and time, I know you guys is having it rough.
Awesome. All right, welcome Eddie, Kelsey, Martha, Patricia, Noah, Jaja. I think we can go ahead and get started. Let's do it. Okay. Jaja, want me to pass it over to you, or you feel good about doing a welcome and
Certainly.
Awesome.
Well, welcome to the first coordinated entry meeting in January 22nd of 2026. Thank you all for being here. Oh, hi, Devin. Appreciate you joining us and seeing everyone. You know, we're here to do the good work, right? And I'm so excited about the pilot program that you guys are working on. And I do have an added email I got from Dr. Leslie Enzian, who is the director of the Edward Thomas House, that I'd like to share later on today if possible. So welcome. And hi, Mustafa, welcome.
Good morning,
Tom.
everybody,
I'm going to pass it back to you.
and Happy New Year for everybody.
Yeah. Thanks, Jaja. Happy New Year, everyone. Yeah, I said Happy New Year, and then I was like, yeah, it's 2026. I was getting ready for today, and I just happened to glance at the agenda that we had created we met on January 23rd last year, so almost a year ago to the day, and just kind of looking at the agenda, we were going over our bylaws and kind of reviewing membership to ensure that we would have enough folks here to be able to make quorum, and just made me reflect on all of the foundational work we did last year as a group in 2025 to kind of get this committee back up and spinning, and doing things together, making decisions for the improvement of the efficiency and efficacy of the coordinated entry system. So I think we've come a long way. We have some new faces with us, some new members with us that joined us this year, Finn, Mustafa, the rest of y'all. Just really appreciate your continued support and commitment to this committee. So without further ado, we'll go ahead and get started. As always, I'll ground us in our theory of change. If we create a homelessness response system that centers the voices of people with lived experience, then we can focus on responding to needs and eliminating inequities. As outlined in the King County Continuum of Care Charter, the Coordinated Entry Committee will oversee policies and procedures related to coordinated entry in King County. The CEC will be responsible for identifying and approving policies and procedures that guide the coordinated entry system. King County Regional Homeless Authority staff will be responsible for implementation of those policies and procedures. I do have one item of business that I want to ask if one of you all would propose a motion to amend our agenda today. Jaja mentioned Dr. to us inquiring about public comment. That's something that Catherine and I and our team here and Kelsey and our team here have kind of discussed back and forth about the role of these subcommittee and work group meetings as being public versus, the COC board meeting public, and then these kind of like subcommittee meetings being closed. As those of you who work more closely with the COC board are well aware, our charter review committee is and has been hard at work revising the COC charter and kind of helping to increase its robustness to kind of give us some better guidelines and oversight as to kind of if these meetings are to be public, what elements of them. And so we just received an inquiry about public comment. So I wanted to add an agenda item. If someone would make a motion to add an agenda item, then we can add a brief period of public comment to our meeting this morning. And if there are, because I've been monitoring over the last, I think, 3 or 4 meetings, there are some members of the public that do join us to watch. And so I'd like to I would like to ask that someone propose an amendment to update the agenda today for a brief period of public comment this morning. And if there are folks with us here on the call, then we can hear from them. So is there anyone who'd like to propose this?
I'll make that motion.
I'll second.
Oh,
Who's
thank you,
second?
Martha.
Great.
So let's do a roll call.
And we'll do a roll call vote. So Catherine, I'll ask you to call the roll.
Devin,
Yes.
Noah,
Yes.
Eddie,
Yes.
Martha.
Yes.
Do we have Portia?
No, she's not here.
Okay.
Oh my gosh.
Patricia
Yes.
and Elliot hasn't joined us yet. Kelsey,
Yes.
Jaja,
Yes.
and Sherry, and Finn,
Yes.
and Mustafa.
Yes.
Great.
You have 9 yes votes.
Wonderful.
Are there any no votes? Any abstentions? Motion passes.
Okay, great. Thanks, everybody. So we'll add that to the agenda up next. Actually, I got a little excited there and I skipped, we voted before we even did kind of like a basic roll call. So thanks everyone for voting. Catherine, I'll pass it back to you actually to call the roll officially for today's meeting.
Officially.
So keep those clickers close to that mute button, everyone, because
All right, Devin,
Present, yes.
Noah,
he said here.
okay, Eddie,
Present.
Martha. Dr. Dr. Sam.
Present.
Martha's present. Just can't press a button.
All right, Kelsey,
Here.
Jaja,
Yes.
Finn,
Here.
Present.
and Mustafa.
Present.
Okay. You have 1, 2, 3. You have 9 members present and you have met quorum.
Wonderful.
Just-
Kelsey,
I see Sherry Tillman in the attendees list.
Thank you, Kelsey. Good morning, Sherry. Sherry, can you hear us?
Yes, I am.
Thank you. So I'll correct that you have 10 members present.
Great. Okay, next thing on the agenda before we move to public comment is one more vote to approve last month's meeting minutes. So is there anyone who'd like to propose a motion to approve last month's meeting minutes?
I'll motion to approve.
I'll second.
Who is the motion, Devin?
Motion from Devin, second from Kelsey.
Thank you. And we can do a voice vote.
Voice vote. So all those in favor of approving last month's meeting minutes, say aye.
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 All
Aye.
opposed,
Aye.
all opposed, say nay. And are there any abstentions? It sounds, Catherine, like the ayes have it.
The ayes have it.
We can move forward. Okay, awesome. The next thing on our agenda is to have a brief period of public comment. So we will open the period of public comment now. If there are, well, actually, Catherine, I'll turn it over to you to help with this because admittedly, I have not facilitated a public meeting where we've done a public comment before, so I will turn it over to you.
It doesn't appear that there's any members of the public in the attendees.
Okay,
So we can.
Can I, I'm sorry. This is Jaja. I want to say that I did get an email and anyway, I talked with Dr. Enzian. We're on other boards together and she let me know that she wouldn't be able to make it today, but if I could read her email. And I think it's apropos, especially for the people who are involved in the assessment pilot work group. So it says, hello, Tom, Jaja, and Catherine. I observed the December CE meeting. Check this out. I'm not going to read all that. I'm going to get to her bullet points. Okay, that's what's important. Okay, thank you to the CE and APW, Assessment Pilot Work Group, and the Coordinated Entry Committee for your work on optimizing the CE process. This work is very needed. Second bullet point, changing the vulnerability assessment tools alone will not be sufficient to optimize the CE process. Many of those applying for CE complete all the needed paperwork, but can't get past the requirement to have a case manager. If case manager assignment continues to be a requirement, I feel that the CE process needs to include connecting clients to a case manager in a timely fashion. Perhaps collaboration with housing case managers at Catholic Community Services, for example, might be an option. And then the third, the current process of requiring each case manager to attend meetings daily to advocate for prioritization of their clients is profoundly inefficient and takes time away from other case management work. Ideally, a new efficient process would replace this. Next bullet, the current CE criteria do not prioritize those who have very serious medical issues, who have a high short-term risk of death, such as those with metastatic cancer or renal failure requiring dialysis. I know she said that because we chatted about that. That was her biggest concern. She has a couple clients who have the metastatic cancer, but don't meet any other requirements to be, so they have to move them from respite onto the street. I guess, I hope that the new process might allow for certain serious medical diagnosis to automatically qualify for high prioritization. In years past, for example, patients requiring dialysis treatments rose to the top of the priority list. Most recent vulnerability scores have prioritized those with issues in many different arenas. For example, mental health issues plus substance use issues plus medical issues, but do not prioritize those who have a significant issue in one area, such as metastatic cancer without mental health or substance use issues. I will be interested in seeing how the pilot housing triage tool will integrate medical illness. Now, the VAT does not include prioritization of medical issues, and I wonder whether using the mini VAT for the second phase assessment will miss medically fragile clients. Please let me know if you feel any of my considerations do not accurately reflect the current or proposed process. Thank you very much for your consideration of these concerns, Leslie Enzian. So there you go. That is our public comment, and I thought that was something that we possibly could discuss, you know, later on another agenda, if not now, because I don't know what our agenda looks like. But when we chatted about that, I was surprised, I guess, that the way our system is set up, that people who are the most vulnerable with medical issues such as that aren't in our priority list. I mean, don't rise to the top. So I don't know exactly what that looks like. So I'm hoping that the assessment pilot program with y'all folks working in that work group, which are primarily providers, right, who deal with people all the time, that I feel like you guys have the best information and, you know, maybe the best insight on how to address that issue. So anyway, thank you. KCRHA out. I'm just kidding.
Yeah, thanks, Jaja. You know what, I think that's a perfect segue, kind of how you're wrapping it up. I was gonna just show a couple of bullet points to just give a very brief update, because I gave a more robust update last month about where the work of the assessment pilot work group is at. And so without further ado, and what we can do, and so Jaja, what we can do is I'll then kind of just get through, really on the agenda today, I just had a couple of brief updates for the group, which I think that I can get through really in the next like 5 minutes. And then we'll have a time period of some questions. If any of y'all have questions, comments, concerns, things you want to talk about, maybe we can use that time on the agenda to also kind of speak to some of the points that Dr. Enzian made in her note to us and some of the questions that you raised along with it. So.
And there's still no one in the attendees that
Okay.
has their hand up for public comment.
Great. Thank you, Catherine. Let's see. Is everyone able to see my screen now?
Tom, I'm gonna say going once, going twice, public comment is closed.
Perfect. Thank you.
And yes, we can see your screen, at least I can.
Awesome. Okay. Very quickly, like I just said, I gave you all a more kind of robust update of where the assessment pilot work group is at. We just had another meeting this week. We are reviewing the first draft of the first phase of a potential triaging assessment that would be piloted in the community, has been submitted to the work group members, KCRHA executive leadership, and our like HUD technical assistance providers for review. And the work group has now kind of like increased a little bit. It's no longer just members of this coordinated entry committee, but our partners from technical assistance, and also Pele Tracy from the UW Information School, who's going to be working with us on the evaluative portion of this. So we met this week. The work group members have reviewed the draft of the assessment tool, and so that review process and editing process is underway. Once we're working through that. I don't wanna, right now, I don't wanna kind of overpromise and underdeliver on a timeline for like when we're gonna be done reviewing that draft document. So I'm not gonna kind of make any kind of like hard commitments to like when we will have a final draft of that document to bring back for this group to review. But I hope we meet again in a couple weeks. And I hope, you know, in that time, it will start to become a little bit more clear to us. Hey, it's gonna take us one more month. Hey, it's gonna take just a few more weeks, it's gonna take a couple more months to really kind of bring this document to the woodshed. And it's not even just the document that we need to kind of bring to the woodshed, but also the process. You know, what is it gonna look like? We can have the tool, but then we also, that's been another part of our conversations is, it's not just the tool, it's also how does that tool get kind of brought to the community, brought to people who are experiencing a housing crisis to move forward. And so once we have a final draft that we feel good about bringing back to this body here, we'll put that on the agenda for you all to review and vote on some next steps. So that's my update on kind of where the assessment pilot work group is at. Like, you know, as we know, many members of the assessment pilot work group are here, so maybe in another second when we have some time for questions and conversation, you know, if you all have things that you want to add, please, you know, go for it. I will just ask, one other update that I want to give you all is just about something that my team here is working on for coordinated entry operations. So last year, I told you all about how one of the biggest initiatives that my team undertook was to kind of reopen and re-engage the community of coordinated entry providers in a meaningful way again. So we reconvened those subpopulation leadership teams, young adult, single adult, and family. And we've been having good kind of tillage of the provider soil, good tillage of the coordinated entry provider soil, conversations about with the folks who are boots on the ground doing the work, housing folks, getting folks into their housing programs, engaging people, assessing folks, getting their documents ready and case conferencing them for housing. What's working, what doesn't work for you all. You know, if you all were in the driver's seat, how would you please, you know, let us know, how would you make changes to what we're doing? And one of the things that we kind of heard most loud and clear was this daily unit posting and daily churn of making nominations like, you know, Dr. Enzian raised in her letter wasn't working for people. You know, there was a lot of dissatisfaction, and that wasn't just from navigators. That's also from housing providers. And housing providers are saying, you know, we think that the fact that people feel under pressure to find folks to nominate every single day, we have a sense that maybe there could be a better way of doing this, because for us as housing providers to get a little bit of better quality matches to our program. So that's one thing that we heard kind of loud and clear from particularly the young adult group, the single adult group. The young adult group, you know, our staff, Nicole and Autumn, have done a lot of work of doing like surveys, multiple engagement surveys with the young adult providers to kind of hear back, you know, what's working for you all, what's not. So, you know, there's been some really great work that's gone on there. This daily unit posting and office hours cadence is just that thing that we heard kind of most loud and clear from the community as something that they think there's big opportunity to shift and change, and that we could see movement in the efficiency and efficacy of the system. So my team's been working through a couple rounds of drafts and some different options about what not having it be a daily cadence could look like. And so that's something that I have been working on. And that process, I think what that will look like is kind of devising and looking through some options there about what, like, maybe only posting 2 times a week and tie breaking 2 times a week, maybe 3 times a week. to kind of balance the best interests of ensuring that we're being thoughtful about who is being considered for housing openings. And then also really also not wanting to sacrifice the fact that particularly for housing providers, one thing that's good is that if a referral gets denied, that unit's going to open up the next day and there's going to be another potentially viable person to fill that unit. So we also want to keep an eye for ensuring that we're supporting the case conferencing and the housing navigator process, but also ensuring that we're still keeping an eye for some urgency, a sense of urgency for making sure that we don't have extended vacancies for all of you housing providers, right? So we want to kind of balance those two interests. So we're working through some different options of what that could look like. We'll work that through the KCRHA kind of like governance structure, as well as working it back through the community, letting them know, hey, here's some drafts. We've already started to do that with both the young adult and the single adult groups. For those of you here on the call who maybe attend either of those groups, you'll have been at our most recent meetings where we've kind of showed you some drafts about what unit posting and office hours could look like. And we've gotten some feedback to inform some further drafting, work that through the governance structure, give that back to the leadership teams for comment, and then ultimately bring that to you all for endorsement. So I'll be coming to you all saying, hey, this is what young adult, single adult, family, our governance structure here at KCRHA is saying, my team, as we think that this could be something that would work best, and asking you all for that endorsement. So those are really my two updates for today. And now it's 10:28. We have some time for questions, comments, and some conversation. Does anyone have any kind of, I guess also too, particularly APW, Assessment Pilot Work Group folks, does anyone have any kind of initial thoughts or responses to like Dr. Leslie's email that Jaja read to us, and kind of anything that came up in that that you would want to kind of share from our work group that might speak to some of those concerns or points?
Sure. I mean, I think a lot of the points that were brought up, well, not a lot, but maybe a majority, are getting addressed in the work group. The revising of the schedule for office hours or nominations is getting worked on. We're redoing the whole assessment. And we're looking at incorporating those health questions back into some type of the assessment, or what that's going to look like. When it comes to case managers having to attend every day, that's just not the case. They haven't had to actually physically attend in years. It's all done through a form. So it's all, even if they do attend, the nominations, I mean, aren't really done there. I think the team redirects them to the form to do. We get that the daily grind is not ideal on those. And so I think, a lot of what she expressed in there is being addressed and maybe even incorporated. I don't know. Noah, what are your thoughts?
Yeah, I agree with that, Eddie. I think, the couple of the only thought I had, I appreciate that. The idea of like super highly vulnerable people not getting prioritized by our system is kind of the rallying call of this work that we're trying to do. That of course is tricky of how you define that. That is always kind of where, as a community, we've been saying that is our priority for the duration of the coordinated entry system. How to identify who that is and what that means has proven to be really tricky. So I think I mean, like on a particular point, like, I mean, the bad attempts to call out high medical needs intentionally for that reason, it is a fair point. It's amongst a suite of vulnerabilities. And I do think that piece is a reality of the level of vulnerability we're seeing in our community, that, you know, the acuity of somebody's need it doesn't necessarily always get factored into how we prioritize them. And I think it'd be great if we could think about that. I know we've done some medical acuity work across our system. Although that to say, not to get into those kind of specifics, I do think what we're trying to do, or my real hope of this pilot group is, we have only so much housing resource in the community. And of that resource, to state the obvious that this group knows, it's not nearly enough, but of the type that we do have, it is designed and staffed and funded and with an eye towards providing supports to people with a suite of needs. And we don't take nearly enough time as a community to find people who need the sorts of resources that our limited housing resources provide, and trying to crosswalk that is what the goal of this, in my mind, of this pilot is. So yeah, I mean, I think metastatic cancer, yeah, that makes someone super highly vulnerable. Does that always mean that somebody needs the kind of supports that a housing resource offers? Maybe, maybe not. And I think that's what we're trying to do. This kind of like really blunt effort of find people and then just stick them to whatever housing we have is what we're trying to get away from. So hopefully some of this nuance will get at what the doctor's raising. So I appreciate, Sasha, you reading those concerns. And yeah, I agree with Eddie. I think that's what we're trying to solve for here.
KCRHA.
Yeah, no, I thank you for that. You know, I appreciate that. And for equity and you know what's fair. I mean, all the different nuances of what's going on, like you said, the suite, whatever it is that folks are coming up against. And you think about people who have those kind of diagnoses that are transitioning from respite onto wherever, right? And it would seem as though the gap in housing is right there. I mean, people who are most vulnerable like that, they need to have, and this is just me, and it came in my mind that we need to help the health industry, public health, which I sit on too, is we need to be addressing some kind of structure, some kind of building or housing for folks being transitioned out of respite who, you know, like, not like a nursing home, but you know what I'm just saying? I mean, if people are able to do their ADLs, then of course, maybe a place that just that vulnerable population has a place to be. And I will run it because I used to run a transition house in Oregon, you know what I mean? But no, I'm saying that is something that's really needed. If you think about it, the need for people who are most vulnerable medically to have a place to be. And that's all that should be in that, you know, in that building is what I'm saying, you know, from the mainstream, from the streets into respite care, or from the hospital into respite, and then from respite into, just like we have with the crisis care centers right now with behavioral health, something like that, you know what I mean? A wraparound service for them. And thank you so much for all the work you guys are doing in the pilot program. I appreciate that because your guys' minds are, I feel like you have the most information. You have that day-to-day in and out, and you probably have been promoted in your job, being wherever you were, you know, but you've seen so much and you have a wealth of information to share in order to bring about a solution in this finite little bit of housing, because that's just the problem right there, is housing, right? We don't have enough of it, right? And so here we are as a coordinated entry committee, given pebbles, kibbles and bits, right? When we need, you know, a mountain, right? And so, you know, it's like, I appreciate y'all. And I just want to say that. Thank you so much for the hard work that you're doing. in that work group. And thank you for Noah for sharing, you and Eddie both, about addressing what Dr. Enzian has already asked about. And I will definitely pass that on to her, that that is being addressed. Because she's doing the hard work also, you know what I'm saying? Any provider and people in your guys' providers, to me, providers are frontline workers, right? And the impact that it has on you, sharing your hope and strength and expertise with people who are most vulnerable has to weigh on you. You know what I mean? I mean, so I know sometimes you probably wish you could just snap your fingers or turn around 3 times or something, make a wish, you know what I'm saying, and make it happen, because you see the same person asking you the same thing, and how, difficult that must be. But I just appreciate y'all and thank you so much for your work. And I'll be quiet, Tom.
Thanks, Jaja. I saw Sherry came off mute. Patricia, I see your hand, and then I saw Sherry came off mute for a sec. Sherry, was there something that you wanted to add?
No, I was gonna just say I totally agree with what Jaja was saying.
Yeah, thank you. Dr. Sam, you had your hand up.
Good morning. Happy New Year, everyone. Hi, Eddie. Hi, everyone. And
New Year.
Tom, can you hear me okay?
Loud and
Good.
clear.
So yeah, I also thanks Jaja for reading those points of concern. And I wish I had them in front of me so I could, focus on them. Also, thanks to the committee, thanks for everyone, the work that we're doing, and me as a frontline case manager. And now I'm in crisis, so I work on the crisis side. I still do case management. And I really want to just echo what you're saying about, I'm thinking the word that came to me is reassess. So I'm just kind of pulling some things out. Don't want to hold every time, but the reassessment, going forward, how we are housing our clients, our folks in the community. And we mentioned, there's a lot of, we're really in crisis. We deal with a diverse population of people, coming from the most vulnerable to our everyday, what would I say, working class people, families that are all of a sudden hitting a crisis, have never been in the system. It's a big rise of eviction going on, people that have been stable in their housing for long periods of time, that all of a sudden there's some health challenges, and that brings about the mental health as well. And then our people are being displaced or uprooted. So as fast as we're putting people in, there are other people that are getting out. And this is overwhelming, because I'm like, what the emergency, where can we put them? And right now we don't even have place. So I just want to throw that out there. And then I took a couple of notes, like the public health, getting our public health. I work with a lot, with the multidisciplinary team. I'm in hospitals. Our clients are going to the hospital. This SI, suicide ideation, and also thought and plan, is real serious. And that's just some of the things. I do want to say that then when we are getting we have this model, they're getting in housing, we're building, and someone mentioned that we're just putting them in the places to fill the building. And I heard the case management is what stuck out to me, is because one time I went to a place and the feedback was, you know what, thank you for coming out here, doing the warm handoff. and being interested in showing some involvement in advocating, working with us, because we're all new here. We just got a job here. We really don't have the experience, and there is a high need, like of diverse needs, all put in a pot together. And so I'm thinking of, as we're going into this new year with all the different changes to the budget, where possibly the funding is going to be lack of funding, a new criteria to our Medicaid, where our clients will have to be able to what's the word I want to use? There are going to be stipulations that they have to abide by in order to stay on. These are just some thoughts. Or they could be at jeopardy for having our state Medicaid. And a lot of things, so here's my point. A lot of times I'm seeing that we get clients in, they've really been out unhoused for a long time. They have other behavior issues. And I'm looking at the component or adding or just figuring out, so how can we think about their needs? I'm seeing people that's just living from a year to a year. And I know we have to go in and assess, do a treatment plan, let's help them do this. But there's some people that have never learned to even how to pay rent. And so and that's a barrier. They want to, but they don't know how to manage. And we're saying, oh, just go to this class. But how can we invent some modalities or something where we can be more intentional? And I know I'm outstretching, but these are things that are on my heart. I wish I could take this on and, start a program where we can really do it, because it's just the fact. And so if they can't and they're not, guess what? One, they're going to just get evicted. They're going to be back out there. Another thing, a lot of our vulnerable people do not have the skills to advocate. So when they're put in these new housing, and there's people that are have mental challenges, health challenges, coming out of respite, dialysis, all kind of things. Guess what? That's just all in that pile, and there's a conflict. It's just like being in the home and everybody's fighting and things going on. But then they're trying to advocate, and some clients are not or do not have the support or feeling they're being supported by our leadership teams, the people that are providers. And I'll just leave it at that. And so I'm doing extra work and engaging and being supportive, but these are just some topics that I'm just throwing out there. That's all I want to say. But really, maybe what could we start adding in to the when we get a person in and being assessing? We have these houses, so like Jaja was saying, having certain houses that are certain specific, and I know there have been kind of, but this really piece of taking our clients that we have, our clients, and really working with them, some skill building opportunities, I know we say meeting when they're at, but also going that extra length to help them to be able to be successful and to learn to be successful in this world that has already rejected them. And if we don't step up and do the work in our own community and help them, guess what? They're just going to be out there with nothing. Thank you.
Thank you, Dr. Sam. Jaja, real quick before I call on you, I just want to say a couple of things. One, so I appreciate all the great discussion. First of all, for those of you who are on the APW Assessment Pilot Work Group, thanks for kind of chiming in and giving some more context and speaking to some of those bullet points that Jaja highlighted for us today. So thanks for including that. The other thing too, I think that's important for us to talk about, and for this group to remain focused on, is the reality that even if we are and something that the work group is discussing, is doing some of that prioritization work based on and like as we're talking about aligning the highest needs individuals in our community who do require the level of supportive housing that is being built and funded and operated in our community, I think requires some cross systems collaboration and support that goes a little bit deeper than just HMIS data can support. And I think that makes me think, and I understand that I'm the coordinated entry manager, so I have a bias, and you might be expected for me to say something like this, or a person in my role to say something like this. I think it's completely valid and legitimate, you know, the concerns and the critiques of why what we are doing right now lacks, and why, you know, and what we've done in the past lacks. But there's also context for why we are prioritizing people the way we are right now. And it actually has a lot to do with the fact that we used to use an assessment system that our community was one of the first in the country to nationally kind of put out there nationally for other COCs to know too, that this doesn't work. You know, this perpetuates the systemic racial inequities that is part of why we're in this position in the first place, with a disproportionate number of people from Black, Indigenous, and other communities of color, marginalized communities, LGBTQ plus IA communities, you know, those who are disproportionately represented in the homelessness population, right? And the step that we took to incorporate, you know, medical grade administrative data with the COVID prioritization to actually be prioritizing people who, you know, COVID prioritization in its most fundamental thing is saying who's most at risk of dying on the streets from health complications tomorrow. And those people should be prioritized for our limited permanent supportive housing resources. We haven't always gotten it exactly right. I think, you know, I personally have some feelings about, like, should you be applying that type of prioritization structure to then say, you know, permanent supportive housing resources aren't the only options available in coordinated entry. There's also rapid rehousing. Should people who are being prioritized for permanent housing also be prioritized only for rapid rehousing? There's some misalignment there that I don't think we've always gotten right in the past. But these are also things that not only the assessment pilot work group is talking about, but my team talks about every day. My team talks about every day with members of all of your teams, you know, in our case conferencing meetings. Like Leah's sitting here, she does a lot of work, you know, with housing providers to lease projects up and talk about, hey, what can we do to be creative to make sure that we're abiding by the coordinated entry policies and procedures, but also getting as creative as we can to ensure that we are prioritizing the folks that need to be prioritized for these slots. Because there's a lot of work that goes into that. But then I think too, you know, the thing that's kind of been highest on my mind, with it being the beginning of the year and looking toward another year and planning our priorities, is we need partnership and collaboration from these other systems. I've been developing some relationships with our partners in jail health services, you know, public health, the people who coordinate health services for kind of like the highest utilizers and the most kind of like short-term stayers in like the King County Jail, who are there the most frequently, but are also there for the shortest periods of time. And kind of like that overlap of those are also folks who maybe come up as utilizing like the psychiatric emergency response system the most often, the medical vulnerability, you know, like So Dr. Enzian system with medical respite, and also kind of like our emergency rooms, and looking at who are the folks who most often use the emergency room as their primary care provider. You know, we're here in the 400 Yesler Terrace building. In this building is also the sobering center, you know, the Pioneer Human Services, King County Public Health Collaborative, you know, sobering center for people who might be experiencing homelessness and also need a place to, if they become over intoxicated, you know, have that health need addressed. I facilitated meetings in the last couple of weeks between members of Dr. Enzian's team at Medical Respite, people at the, you know, 1811 Eastlake, you know, the DESC 1811 Eastlake building, to make sure, like, hey, coordinated entry, this case conferencing system right now actually isn't really getting it right in terms of aligning the high needs individuals with severe alcohol use disorder who might be utilizing these sobering service centers and are homeless, or might find themselves in medical respite and needing some of those resources at 1811. How do we bring you all together? Because we know that we can't do it alone. And we know that we actually need to bring the community into, and also I will say, I think for me, my posture and stance at this year is also one of wanting to open the doors and invite that collaboration. I think, frankly, it also comes with a little bit of challenge to some of those partners too, to be like, we have opened the doors to you all in the past, and we have tried to build these structures in the past for case conferencing. We all say together as a community that this is our priority to try and get this right and do this work. We need your steadfast partnership, because I think what we have found, some lessons learned in the past, in my data and information gathering from interviewing people who've had this role before me and talking to people that I've worked with in the past, is that, you know, to put it, you know, briefly, is that it's not always if you build it, they will come. Sometimes it's built, and sometimes not everyone arrives at the table. And so, you know, I think my posture and attitude this year is both one of openness and invitation. It's also one of challenge, to say, you know, people state that this is a priority for them. I'm going to be asking them, and I ask you all too, as our partners and members of this community, to notice who those folks are who are stating that this is a priority for themselves, and asking to ensure that when that opportunity, my commitment to the community is to build and set the table to facilitate these conversations. My challenge to the community is that they continue to show up and collaborate, because my team can't just do it on our own. We need them to not only put the pressure for us to create the structures, but we also need them to show up to actually continue to make sure that the work is done. And I don't want to sound scandalous. I don't want to sound kind of not collaborative, but that's, I think, 10 years of coordinated entry era and lots of conversation with people who've had this role in the past and have tried to do this work. Is I think that is a lesson learned, is that we can build the things, we can set the table. It requires a steadfast commitment, because another thing with coordinated entry is this is the system that folks need when they are experiencing a housing crisis. This is a system that folks come to when every other system in our society has already failed them. And the conversation can't be, okay, coordinated entry, what are you going to do to make up for all these other rungs and layers of systemic failure? That's not realistic, and I don't think that that's a fair or valid conversation starting point for, well, we need the system to be the one that cures all of the many layers of systemic failure that result in people becoming homeless. And it's just gonna, that like we're saying, with the situation of housing being what it is, that then somehow this system is going to magically cure all of that. So I think there's some level setting that needs to happen there. There needs to be some realism about what this system is and what it's designed to be and what it is not. And then it also is my invitation and challenge to folks of, if you want to come and help us, if you feel that you know that we're not doing some things right, which we know too and are very clear-eyed and realistic about, then I'm asking for their partnership to make some commitments there to ensure that the good ideas that folks have are actually able to take root. Thanks for that's my soapbox for the day. And Mustafa, I'll call on you. And then I think we'll have some time for Mustafa's question or comment. And then I think we'll move here to close because we're getting close to 11. But Mustafa, go for it.
Thank you so much. You mentioned communities, our communities, and then you divided it to, LGBTQ non-binaries and the others, BIPOC communities and NATO. So you didn't, include the immigrant status also? Because we know lately what ICE did and about the immigrant status, and there's a lot of deportation because they also struggle with that. There are refugees or immigrants, because even Trump now deport people. Like I know, 800,000 people have green card. They have been deported, and they are also struggle with homelessness. This is the first one. The second question, you speak about the partner. I'm a board member in the King County, the health board. Why you don't partner with the health board through the King County? Because me and Dr. Lamont, Jaja know that we are the board members. So because we have working last year about something called CHIP program, Community Health Implementation Program. I don't see you there one time. So if we can partner with them, or I can connect you with them, that's going to be helpful.
That would be fantastic, Mustafa, because I'm actually, and I love that you raised the CHIP. Someone told me about the CHIP last year, and I reached out to them to ask to invite me to those meetings, and that never happened. So if you do have connections to that group, I would love to talk with you more about how I can get involved.
I'm in this group because they voted for me from King County to be in this group. So we are 3 people from the board health and the King. So I can connect with you. I even can invite you one of the meetings.
I would love that. Thank you very much. I'll write you an email, Mustafa, actually, after we wrap up this meeting to follow up on that.
I cut you. So can you just answer the first question about that?
Absolutely. I think that topic about immigrants' rights and where it intersects with homelessness, thank you so much for raising it, because that is another piece of the conversation that I think, especially right now, needs to be much more centered. And there are some kind of cross-cutting challenges and questions about kind of like, frankly, like the eligibility of certain programs that participate in coordinated entry. Like, I think that for a lot of individuals and families who are immigrants, asylum seekers, refugees, etc.,
besides the religion, regarding the religion, there's Muslim also. Yes.
Regardless, right. That there's programs within coordinated entry that could be good fits for those individuals and families, like say maybe rapid rehousing or diversion services. And then the vast bulk majority of these permanent supportive housing services, I want to be very careful with how I word this. I think that the chronic homelessness and the disability requirements usually create for a situation for where that might not just be the greatest fit for every family or individual that is in need of housing services. However, certainly there's crossover for folks that it would be a good fit for. And I think too, that actually, Mustafa, goes back to my other comment about how people come to coordinated, because people think coordinated entry and they think housing and they think all housing. And actually, I think this is something that my team talks about all the time, is that how we were originally branded as coordinated entry for all has sometimes done a little bit of a disservice for being, I think our system could actually do a better job of level setting with the expectation setting with the community and being more clear and direct about and realistic about what we can offer and what we can do and what we can't offer and what we can't do. What we cannot be is a magic wand that's going to say, if you are experiencing a housing crisis, anyone, that we're going to have a solution for you. That I think I don't enjoy saying that. I would love for us to be able to say that as a system, but we can't, right? And I think that actually then there's a respect and integrity that comes with saying that, of being realistic about what we can and cannot do. And I think that I've engaged in conversations with people who are serving families and individuals who are asylum seekers, refugees, and migrants, and fielding, and justifiably so. There's a lot of anger and confusion and a sense of urgency for folks to want to stand up and do what's right, to advocate for those that they know are suffering, and fielding some of that, and people saying, like, why isn't coordinated entry doing more to be able to have answers for many of these families? And the reality is because we don't have access to all the programs that actually might be a good and correct fit for some of those families. And sometimes talking about that can be difficult because there's a lot that goes into it. But I also think that goes to what I'm saying about this piece of that there's also other systems, and I am so interested and so motivated to connect more with some of these other systems and programs that maybe they do have housing options or benefits options and services for refugees and asylees in particular, right? Like, that is certainly out there. It might just not go through this system right now. I would love to talk with people about how we can better, because at the end of the day, and I think with experience under this community's belt in like what is coordinated entry, I have really leaned into thinking about it as like front door, the front door to folks experiencing a housing crisis, and really trying to work with folks experiencing a housing crisis from like an emergency room standpoint, like the housing and homeless emergency room, if you will. And how can we triage you to what you need? If you are an asylum seeker, a refugee, or a migrant, maybe permanent supportive housing isn't right for you, but maybe this other program is, and we're able to help triage you to what that is. But I think this idea of a kind of universal and unified front door is kind of like the ticket of where we might want to go. So.
Yeah. And through my experiences, by the way, always I found the health connected to the homeless, like
right.
The home, sterilization. And what I like, when I say health, it's mental health and physical health. Both of them connect to the homelessness. All of, like, this is like not just overlapping, it's both of them, like, so this is why, so that's why we created the CHIP program, and we're working from that, for the King County also. This is the ultimate goal.
Yeah. Of course. No, thank you, Mustafa. Really, incredibly important conversation topic right now. And I've actually been talking with people here at KCRHA as well about just ensuring that we are also doing what we need to do and fulfilling our role in the community of supporting our providers in people knowing their rights for what to do. Because it really does feel like at this point, it's not a matter of if, it's a matter of when we are going to encounter ICE in our communities and knowing our rights and understanding the rights of people experiencing homelessness, migrants and refugees potentially experiencing homelessness, or just anyone experiencing homelessness, when they're encountering those federal authorities. So incredibly important and timely conversation. So thank you.
Thank you a lot.
Thanks, Tom, and panel. It is 11:05, and I just want to thank y'all for staying over the 5 minutes. What a robust conversation. I believe that coordinated entry in 2026 has its work cut out for them, but we're headed in the right direction. Thank you once again for the AWP program work group and the coordinated entry staff, KCRHA, Tom. Thank you, sir. You all have a blessed day, and it's time to adjourn this meeting.
Is there anyone who'd like to make a motion to adjourn?
I motion that we adjourn.
I'll second that.
Thanks, Eddie.
Awesome. Okay. All right. Thanks, everybody. Happy
Bye.
New Year. Thank you so much for your conversation and partnership, and we'll see you next month.
Thank you.
Thank
Thanks,
you. I just
Tom.
put
Thanks,
my
Jaja.
email.
Thanks, everyone. Take care.
Okay, bye.